Good morning and welcome to our 10th session of ccclifecases.org. I'm Samir Mehta and I'm delighted to have you join us. We have another genuinely complex coronary case for you, and not only will you get a chance to watch this case but get an excellent didactic. You'll come to understand the rationale, the reasons behind performing this particular procedure and the evidence-based data supporting what we are doing. We have a truly complex case today. Within a single case, you are going to see crossing of a total occlusion, left main, and much more. And for the first time also, we are live streaming on your Apple iPhone. So just go to the icon, follow the regular instructions, and also let your questions keep coming. Without any further time on my introduction, I'm going to take you to the cath lab. Sameen, Anu, good morning.
Good morning.
Okay, good morning and welcome to all. And as you mentioned, it's a very ambitious 1 hour. We're trying to do this complex case, which very complex history. And of course, we have taken our CC live cases symposium to the next level to be able to log in through the iPhone and iPad and so. With that, this is our case number 10. A 48-year-old male had recurrent exertional angina with positive stress test for multivessel ischemia. History basically is that he has history of hypertension, high lipids, non-insulin dependent diabetes, and he had a cath last year in February, during which he had a left main and 3 vessel disease. Syntax score was 34 with EF of 40%. That time because of extensive disease, and this is where will be the focus of our brief presentation today on the syntax score. Patient was sent for surgery, rightly so, appropriately indicated, had a CABG with a LIMA to LAD, SVG to OM1 and SVG to RPDA. As you can see there, that only one arterial graft, 2 venous graft, which is the routine practice. Many centers will put arterial bypasses, but in diabetics, there are some questions whether they will use a arterial bypass. But I would say you take 100 of these patients, 90% will get the LIMA and 2 vein grafts. Now then patient start having chest pain for last few weeks and has a stress test positive for multivessel ischemia, has been on good medical therapy as you can see there, and for which we brought him for cardiac catheterization, and we can show you actually the catheterization. At that time, maybe just wait 1 second then. Don't go to the cath. Let's just finish the history. That cath at this time showed a 3 vessel and left main, 80%, and EF now slightly better, which is 50+%. The LIMA to the LAD is patent, but distal LAD has a severe diffuse disease. But vein graft to RPD and OM both were occluded now. Then LAD, of course, has I mentioned severe disease filled by LIMA. Circumflex has angulated lesion, which we'll show you, and with a totally occluded that OM1, where the bypass went, and there were 2 lesions in the RCA, proximal and PDA. That time we decided, because patient now within just a year after PCI, CABG came with the symptoms, so that we did a PCI of the RCA and RPDA with the Zions V stent. And plan was to bring the patient for the other vessel, remaining vessel intervention. Now during this time period, actually maybe Anu can highlight in terms of the risk factor profile of this patient, that were they contributing to any of this graft occlusion, because this is unusual. Both venous grafts were gone, and LAD even before the bypass has some disease distally, but now has become very extensive.
Yeah, he had a hemoglobin A1C of 9 when he came to us last year, and at that time he was just on oral hypoglycemic and was changed to insulin, and hemoglobin A1C when he presented during the last cath about a month back is now about 7. But his lipid profile, he has a total cholesterol 207 and LDL of 138. This was his last admission, and he's on a Zocor of 40 at that time, and primary doctor the plan was to change him to either Lipitor or Crestor, and this thing could have partly been responsible for his graft closure also.
Okay, now what we have done here, and this is the angiogram. We can go to the angiogram now. This is the right coronary with 2 stents. In the RCA proximal, it was a 4.0, and then PDA 2.5. And very interesting that the right coronary fills a large obtuse marginal. You see that? But there is a large OM. This is where fills by the collaterals, and
both the bypasses to the RCA and the OM are occluded now.
And this is actually the LAD. See, the LAD is good. I mean, LIMA is good. Mid LAD attachment is fine, but it's a distal diffuse disease. The long segment of the distal diffuse disease, you can see here, and LV actually has improved significantly. Was last year 40%, now I would call it 50 plus.
Yeah.
There's a mild LV dysfunction, and this is the vessel in question. Left main with the angulated circumflex, and you can see the stump of the OM. See, just after a very small branch of that bifurcating OM, there is a proximal, very angulated circumflex, proximal left main, angulated circumflex, and occluded obtuse marginal. That's where we are in this particular case, and we know that by collaterals that we see the OM filling retrogradely. So our goal is now start with the circumflex and OM, and once time permit, go to the LAD on live. Otherwise, we still will going to go with the distal LAD via the LIMA, and since it's a diffusely diseased, mildly calcific, we might end up in doing the rotational atherectomy, and that's our plan. Now, having said that, while we are getting everything ready, let me just quickly go through some of the points that in this complex case, that we have few devices for the tough and complex lesions, besides what we used to have rotational atherectomy only. Plaque modification in some complex cases, and important of the syntax score in our day-to-day life in terms of the lesion complexity. New devices, rotational atherectomy with the distal microchips, diamond burst with the calcific undilatable lesion, very useful device. That's the only one we at present. The in mildly calcific osteal lesions, inelastic lesions, that we use either cutting balloon, which is now the version being flextome, or angiosculpt. Angiosculpt is a wire around a balloon, and basically the idea is that at low pressure they can cut these inelastic plaques. Then in sometimes your wire is there, but you cannot advance, your balloon does not go because of the tough lesion, so that you have this tornus device by Abbott. An idea is that in tough lesions, that after the wire you can advance, and then you can exchange to your either rotational atherectomy wire or with the other high support wire, and can advance your balloon and PTCA. Now there are a few new additions in this field of the tough lesions where wire has gone. One is the Corsair, again with the Abbott, and this actually is the 5 thin wires around the 2 large ones, and it basically gives you that pushability because of the platinum coil, and gives you nice push for the tough lesion. So the Taurus versus Corsair, we used to use quite a bit of Taurus. Now Corsair has become our useful device because it really goes very smoothly, and goes to even very tough lesions where a couple of cases where Taurus did not go. There is another device which is called Gopher, and basically again like a screw in a tough of the vascular solution, so that you can just screw it in the lesion, and of course purpose there is that after that you change it to another catheters, another wires, and your balloons and so. Then the Venture is actually, if you remember, the lot of magnetic system came into the cath lab in the angulated lesion, lot of publications that takes less time to go into the angulated lesion using Magnatax and so, and basically one device in my opinion which put the death nail on the magnetics in the interventional cardiology is the Venture. That is that you can change the direction of the catheter tip to 90 degrees so that you can go to angulated lesion, and this is a very nice demonstration. And actually what it does, it is not only changes the direction, the back, it many times when we try to do, as you can see in the schematic diagram, that wire prolapses. But now Venture, by making this 90-degree angle, like in this particular case where you have the left main and circumflex, gives you the back support of the wall, and that's the important. So that now you can advance your wire and subsequently exchange with your other catheters. Now few other devices we have. One is that Osteal Pro. It's like a prong which is staged at the ostium, particularly very good for the osteal lesions, aorto-osteal lesions, left main or right coronary artery, and gives you precise stent placement in the ostium. We have used some of it. We are not really much happy because of little complexity, but yes, it's a good device. Those who really not comfortable doing the osteal lesions because they worry about osteal RCA stent coming back into the main vessel, is a good device to be used, and it's available. Then for the thrombotic lesions, we actually have the clearway infusion catheter, which is a micro pores at a low pressure so that the local drug delivery. This is another device, but that's more for an acute thrombotic lesion, and there is a study done cocktail showed to be benefit. There in some cases it's really beneficial. Now modification, which I have shown it in the past, that most of the time we just go with the PTC and stent, many of the direct stenting, but in some cases pre-treatment with a debulking modification is required in a complex lesion, which could be 5 to 20% to get a good results. And those are lesions basically are calcific, undilatable, bifurcation, osteal lesions, side branches, total occlusion, unprotected left main, and many times the native vessel after the graft occlusion. Then lastly, being the syntax score, we learned that there is a complex trial done for a complex lesions, whether PCI versus drug-eluting stent using Texas, and they used the syntax. Basically, can angiographic morphology dictate the patient's subsequent outcome, and that was the concept. And 1 year data we have presented before. Last year the 2 year data were presented, and now this year in European Society will have a 3 year data of this randomized trial. 96% follow-up of these 1800 patients, and as you can see there, that syntax score is based on the lesion morphology and where the lesion is. And of course each lesion and the vessel gets the particular number you calculate, and overall in the trial the syntax score was 29 and 28.4 respectively in CABG and Texas group. They were kind of matched in comparison, and of course, as you know, the 2/3 was the 3 vessel and 1/3 was the left main in the trial. This is the data which we have shown, published in NEJM already, that from the death, MI and stroke were identical at 1 year, but clearly revascularization about 6% higher in the DES group, which drove Mackey in favor of CABG. And of course, once you go to the individual syntax score, 22, 23 to 32 or 33 and above, there was a clear-cut gradient in terms of PCI. You can see the PCI Mackey continued to increase, while CABG actually the Mackey continued to decrease with advanced syntax score. Very important observation that more complex angiographic lesion is, and that CABG is great, while the DES, because of the multiple stents, cause more adverse event. And of course, same thing true even for the left main group if you apply the same syntax score. Now, of course, the diabetic patients, the similar data which we found at 1 year. Now they presented, as I mentioned, this is the 2 year data and the death rate. You can see that 1 year it was 3.5 and 4.4. Additionally, 1.5 and 1.9 respectively came, and then therefore at 2 years the death rate still favors the CABG group by 1.3 higher death rate compared to Texas DS. Now, as far as the CVA, the PCI continued to be superior in the CVA. As you can see here, p-value still remain 0.03 with a 1.4% lower CVA in the DES group. Then myocardial infarction, and this is where I think we need to be very cautious and humble. That you can see there that at 1 year there was no difference, the MI rate 3.3 and 4.8, but after that there was absolute 1.1% increase in the MI. Therefore, now at 2 years in the DES group there is higher MI rate, not in 1 year but after, and we can expect because of the 80 to 100 millimeter lesions covered by the stents, stent thrombosis, and all this comes into play, which becomes very important for the freedom trial we just completed 2 weeks ago with the 1900 patients, and we need to be careful, and of course we have to patiently wait for the results by 2012. But key is that myocardial infarction does increase in a Texas DES compared to CABG group, so that if you take those 3 endpoint of death, CV and MI remain same, 7.7, 7.6 at 1 year, and at follow-up also 10.8 and 9.6, but we lose that edge by 1.2% higher event rate. Revascularization, we knew already that higher in the Texas group, now actually it's almost more than double. Initial difference was about 7, now becomes almost a 9% difference in revascularization, and this leads to the overall Mackey in favor of CABG, that now curve separated 7+%. Now, what about based on the syntax score? The syntax score in terms of the low score, medium and high, less than 22, you can see that identical at 2 years, that once you get to 23 and 32, the difference goes in favor again with the CABG, p-value just making it to 0.06, but once you go to the higher syntax score, clearly there is a 13% advantage in the Mackie in favor of CABG compared to DES, and largely these are driven by the revascularization and some by myocardial infarction. So these are the basically data that at least for the hard endpoint you can say there may be no difference, but revascularization, myocardial infarction in a high complex group is higher in the DES group compared to CABG. Now this is very interesting slide, and I'll just will be my last slide on this issue. That is that if we take the CABG registry, the patients who could not go for PCI because of complexity, physicians decided went for CABG. Look at the 2-year Mackie is 12.9%, and of course for the PCI, if we felt that CABG is highest because of comorbid condition, their event rate even with the PCI at 2 years was almost 30%. Now respective numbers are there. That PCI registry event rate was higher than the randomized PCI, but clearly the randomized CABG had a lower event rate. Randomized CABG had a actually higher event rate compared to the registry. What basically it means that once you decide based on the lesion complexity, CABG gives you very good outcome on a long run. So just that message, I think we practice here at Sinai also, that the patients with the complex disease with a syntax score of 33 and above, they routinely get a surgical consultation. And with that note, I think Anu is ready here to start this case with the angulated left main and circumflex.
Samin, yeah. Excellent overview, a very practical summary of the follow-up on the syntax. I'm sure the viewers are going to find it extremely beneficial. Unfortunately, our patient appears to be a fallout from the excellent result which one would customarily find in outcomes with high syntax score and CABG, and you have a challenge ahead of you. I'm actually quite impressed that despite 2 vein grafts closing, the ejection fraction has almost improved after a year. And the other impressive part is that indeed you have a very angulated left circumflex coming off the left main. Looks almost an ideal case to attempt with the venture catheter, which I have always kind of figured out as a mini Amplatz guiding kind of a catheter, which provides you support from the contralateral wall and still has the deflectable tip. So good luck with that. The only other addition I may have added to your outstanding presentation is that in addition to the cocktail trial with the atrium catheter, the infuse AMI trial will give us a lot of information. Anu, what is your plan? What do you have with you?
Yeah, we have a 6 French sheath in the right groin and a 5 French on the left side. That is if you need a contralateral injection when we are doing the circumflex. And there will always be an issue whether you need to go with the 7 French. Ideally, in our institution, majority of the cases, unless we are planning a bifurcation stenting, we do with most of the cases with the 6 French sheath, and we have a long 45 centimeter Terumo sheath, which is the choice of most of the attendings in this lab. It gives a very good support in this kind of tough cases. We need a lot of support when we are trying to go through the left main, and we have VL guide. As you see here, the way it sits, it gives us a good support. Because of the left main disease, even while doing diagnostic, we had some damping, so we had to make some man-made side holes, and the MAC guides, actually we have custom made guides for mostly on the right side with all the side holes that they come. Now I have the venture catheter ready here. I have taken the over the wire venture, if you see it, and as you see, this is how it happens. Clock, you can change, and when you counter, the angle, the tip that's deflected becomes straight. So we have that ready, and I have a feeder with a little curve, and that's how we are going to use to get in.
Looks extremely easy to use. I remember having used the pilot wire several years ago, which was the same concept, but not half as simple to use. 2 quick questions, Anu, which have come through. One for you, one for Samin. Both of them are from international sites. Anu, the question for you is that for this kind of a patient whom you have already done all the risk factor modification for his aggressive coronary artery disease, would there be a role to either increase the dose of Plavix or switch him to Prasugrel?
Okay, now very good question, and I just wanted to tell you is we still, I don't think risk factor modification we have achieved with regard to his cholesterol, so he will be changed to Lipitor Crestor to make sure his LDL is way below 70. We just checked his Plavix responsiveness, and based on our Ecumetrics assay, we got his Plavix response that he's a non-responder, is 31%. To say responsiveness means you need to have a number of 40%, he is 31%, and we see that mostly in the diabetic patients, and this guy probably is not. So that was a good question that was asked, and at the end of the procedure, he's young, we will change, he has no contraindication. The important contraindication for Prasugrel would be people who are older, above 75, with a low body weight of 60 and less, or any history of CVA, TIA in the past. He doesn't have any of these three. So at the end of the case, right now he's sleeping, we'll be changing him to Prasugrel. We'll give, though he got a loading dose of Plavix, the question comes, what do we do now? And we know he's not responding, so we will give 60 milligram of Prasugrel later on, and then leave him on a maintenance dose of 10.
Excellent, Samin. I would traditionally use a mini cross or one of those mini little support catheter to make this curve, but I'm very interested in seeing how the venture performs. Samin, question for you here.
Counter?
That this is highly speculative. That do you think the long-term results of incredible trial like Syntax could be different if you had a substitution of a Zyme stent instead of Ataxis?
Yeah. Okay. See, what I did was I counted the clockwise rotation, so you could see the angle of the venture actually became more suitable for the wire to go through. So now what you do is you cannot advance the venture with that angle.
Yeah. You
see what Dr. Sharma is doing? He is going to counter it out. You straighten the angle. Now it becomes like your any support catheter, and you are able to go further down. We'll go to 300
Excellent
wire.
demonstration and very impressive.
So now we have a 300 wire. The question comes is same. Two ways to take it out. One, either now you change to 300 wire because this is the over the wire venture system. Take it out and go with any kind of a support catheter to work on your CTO. Other thing is you could leave a balloon in the guide, dilate the balloon, and then take out the venture. We went with the first one.
Yeah, I actually don't use that often over the wire, because I think once your venture goes on the side, you can take the venture out and you can dilate with the small balloon, and then of course you go with the bigger balloon. Usually I probably would have gone with the monorail venture, although that going with, the key is that where the angle is of the side branch, you keep rotating. So I did not rotate it completely, because otherwise I would have put the wire. We wanted to show that initially with the less rotation at an angle of about 50, it was going into the OM.
Fine cross.
And
Samin, in this particular case, did you have to rotate only in one direction, or you kept
just one
Stent
direction
first?
Yeah.
No, we'll not be able to.
No, stand first. Yeah.
Then things may not go further down.
Yeah, the question
CTO.
comes is,
Let's get the CTO first.
no, but this one will be tough otherwise. You want to do it first?
It's okay.
The question is that now, do we stabilize the left main and the proximal circ before going into the CTO?
Well, considering
If we put a stent in the left main, look at that angle, we might have a lot of difficulties in negotiating any further stent down in the OM. Right now, let's just, the other only other thing about the over the wire system is that if the good thing about over the wire system venture is that if at all you need to change the wire, it will be much easier. If fielder was not working, the next wire that we would have wanted was Whisper.
But the venture actually, to me, in these difficult cases, I think it's okay. You want to tie, you want to use additional device of $700, $800, but if it takes you more than 30, 60 seconds, just go with the venture and you'll be done right away. Which wire you want now?
We have the new Progress family wires. Give me the 40, yeah. 140. 140 is equivalent to confianza 9.
Let's start with the confianza.
Yeah.
Anu, what has been your experience with these wires, and why would you prefer it over confianza?
The confianza that we carry, when they, as you see, the tip, the tapered tip. The difference between the progress family versus the confianza is that this is equivalent to, this is the tip is equal to miracle 12. They're saying, but more important is it's a combination of your body which is hydrophilic, but the tip is hydrophobic. So it's a combination of your fielder plus your miracle, which you have both. That if you have crossed the lesion, you are able to negotiate your device or any catheter easier through that. But only thing is the tip taper is not as good as the current confianza that we have.
Now this is our fine cross after taking the out. Now we trying to get, remember this is, you have to pull it back proximally. Ready?
Yeah. Now what is that? Are you in the?
No, we are not there yet. So now we need to make a little better curve, or you are ready with this curve, which will be okay. You ready with?
Yeah.
Yeah. See, we have brought it proximally. Therefore now after the venture is out, we have used the exchange length wire, a little die. So now basically we need to go to the lower branch, and this is where it is. Now you want to advance. So now we have fine cross has brought to the ostium of that bifurcating OM. Good.
Good. Now this is a very important step which Dr. Sharma just showed, because if two people are working, you cannot ask the person who is to your left to advance the catheter. It's one person's job. You are going forward, and then advancement of the catheter has to be done by the same person. You are using your right hand, you go forward with the wire, and you are advancing your catheter with the left hand, so that you have a tactile sensation in your hands, because if it's one person pushes too hard, guide the wire, everything will come out. So it has to be one person's job.
Now we actually have the contralateral in case is necessary. The people will, we have the JR4 catheter ready, diagnostic. I don't think we need to go with the guide. That's what we do usually. And get a little die, because this is where the branch is. Keep holding the guide. Yeah, little die again.
Yeah.
Yeah. So now go with the other side.
Yeah. Both the wire seems to be moving freely in that. I think since we have the access, it's better we take a picture to make sure we are in the right direction. Okay, pull back, pull back.
Disconnect from there. And to me, one of the important advantage of the contralateral injection, once you're planning the total occlusion, just go with that. Don't change in the middle, because that will increase your success, because it will limit the distal dissection which you have created, if at all.
So, I mean, which brings us to another question which has just come in for CTOs. When will you not use a contralateral injection?
Well, I mean, if the ipsilateral
bridge collaterals are really huge, and you can see the distal vessel really well, and you know when you are doing your by your device, the bridge collaterals are not going to close off the distal vessel, then you don't need a contralateral injection. No.
Yeah. So now you can see here clearly that we have gone into some other different small branch.
Right.
Distally, so they will pull back now. And now will be more guided by the contralateral.
Another very interesting question has come up, which I think the answer I know is almost straightforward, is that what would you have against a strategy of doing just the lesion which makes the most difference, which is the LAD and the left main? And the answer, of course, is the multiple perfusion defects.
Yeah. No, and then I think the LAD, again, as we said, that proximal LAD is just supplying only the septal, and distal LAD, I'm not very happy.
Talking about LIMA.
Yeah,
LIMA to LAD.
The distal LAD through the LIMA. No, I'm saying that here, if we go from the left main, I would say our goal here should be to protect the circumflex, because that's a bigger vessel. Now, proximal LAD has the disease before the septal, so that you need to be careful. that LAD does not close. So that here, if I had to put a stent, I'll take care of the left main and the circumflex and LAD plus minus. For that, going through the LIMA,
Give me confidence.
yeah, going through the LIMA is a big issue because it requires rotational atherectomy and it's a diffuse disease. Therefore, I won't count that much, and clearly the circumflex is a very big vessel. Now you can see here the wire has gone. Now we are going to inject.
Okay.
See?
And that's the value
Yeah.
of the contralateral.
Yeah.
Yeah, but you saw that I had to come all the way proximal and do a re-entry right from the beginning.
Right.
And just by engaging the guide into the left main, despite the side holes, there is a dampening of the pressure, there is ST depressions. But we all know that these are transient, and we have that exchange length wire still again.
Yeah, we have the 300 wire.
Probably also important to point out that the wire tip remains constantly free at all times, and
Show me the ISS.
Samin,
Remember, there is a distal disease there also. You want to go into the top branch.
Yeah, but we can do that without the wire.
Samin, I want you to comment on your choice of radio contrast agent for most PCI in your cath lab.
Yeah, basically, actually, we are using ISO view in all our patients, and we actually was part of the care trial, and we actually have the 2 supplements which have come out since then in terms of choice of our contrast agent, and which really looked into it even in diabetic patients with a high creatinine. Originally based on the nephric data, they felt that iodixinol, which is the low isoosmolar, the 290 milliosmolarity of the blood, is as good as or better than the low osmolar, but clearly that was compared against the omnipaque. Yeah, but omnipaque we learned, and this actually has been now incorporated care trial, and there have been a few other randomized, the 2 small randomized trial led to a meta-analysis, so that now there is a guideline change. In ACC 2007 focus update, in acute coronary syndrome, the patients with a diabetic, selective use of iodixinol or which is Vigipaque was recommended. But now, you want to pull back the over, yeah. But now clearly that based on the available data, it seems to be that as long as you are not using the omnipaque, it's perfectly fine to use other low osmolar agent, whether it's OptiRay, IsoView, and so. So that's where we use. We do not use the iodixinol or Vigipaque.
Wire is useless.
You want to use the filter wire, or which one we want?
Or the
Okay.
wire filter, the 300.
Yeah, we have. But now see that here. What happened is we advancing the extra support wire in the tortuous, and this is the where there is a second subtotal lesion, and the wire getting little hang up. So we probably need a hydrophilic wire of over the wire fielder, and to get the main lumen. Yeah, this wire tip is actually gone. That's the reason, which is not uncommon once you are changing multiple times and rotating them multiple times. But this is what basically is. Now you say, well, I have been using iodixinol, which is the Vigipaque, and it's better for the cases, and so I understand that. But the point is that cost-wise, as you know, the cost is almost double cost, if not like at least 80% cost. If it is available in the same cost, I think it doesn't make any difference. That's fine. But once if it is the cost is high, you need to be, there is no reason to support at this time use of superiority of the isoosmolar contrast over the low osmolar contrast.
So almost 100% of your cases are being done with IsoView?
Right. Now, with the about 1% cases of the peripheral, our endovascular intervention, because what is the advantage of the Vigipaque is that it caused less pain. Though some of the arterial by our endovascular cases by Prakash Krishnan, he does use them basically in those selected cases, but otherwise for the coronaries, majority of the endovascular intervention, only catheter, only dye which is used is IsoView.
We are subintimal.
Yeah, it looks like that we are a little subintimal, so why don't you pull back your catheter a little and then try to rotate, give a torque. It looks, once you have gone to the subintimal, then issue remains that whether you need to use a parallel wire technique or pull back and try again, and knowing that earlier we were there.
It's almost like the second of those subtotal occlusions.
The second lesion,
Because the wire was handling very nicely before.
Because there was another subtotal lesion at the level of bifurcation. So now here actually we may use a whisper.
It's a very long question, Samin, which has come. People are quite observant. There is a viewer who writes
Why don't we
that
just take this?
they read some large description of your cath lab where it was reported that no patient amongst 6,000 PCI went for emergency CABG. Is that true?
Yeah, last year of the 5,800 cases, we have 0 patient for emergency bypass. The year before, we had 2 cases. But last year, 0. No patient went for emergency bypass. Actually, we had a no emergency bypass both in 2007. That time we did about 4,600, and last year the PCI. Remember, PCI last year was 5078. Total intervention was 5,800, including aortic valvuloplasties and so. But taken all that together, that no patient went for emergency OR defined as surgery on the day of PCI.
No, from the cath lab.
From the day of the
Cath lab
PCI or from the cath lab for any complications. And only 8 patients had untoward outcome. But yes, nobody went for surgery from the cath lab. Now clearly these vessels are very friable. Particularly we know the circumflex is usually has very prone for dissection. And there are various ways to deal with it. That do you want to go with the parallel wire versus the same wire, try to get to the main lumen. As long as you can get to the distal lumen, that should be the goal. And here it looks like, no, you need to go to a little distal further. Now what you are having in the tactile sensation? Let me check.
No, the tactile sensation is same. You are not able to, we are not, everything is not transmitted because of the angle that we have at the left main.
The other question is that I still feel that we should stabilize the left main and proximal circumflex, do the balloon dilatation, so that this ST depression, which are happening and dampening, which will give us a little extra time to really deal with it. Or let me just try one again.
Okay now.
Is it in the lumen?
Okay. Let's see.
Pull back the catheter a little bit.
No.
Okay, we are giving us contralateral injection. You will do it a little. Go in cine. Not yet. I'll tell you. When you do a contralateral injection first, and then integrate later. No.
Very hard to make out in that view.
No. Let's study that a little bit. Now, right now is the decreased flow. Part of that has been. Wait one second. Let's analyze where we are.
Now we are subintimal still.
So then we have to pull back quite a bit and redirect right from the beginning. You want to go with the miracle or? Okay, just 1 second. Wait. Good. Now let's see where exactly we became. We try. Now this is the contralateral, as you can see here. This is that before. What has been created a problem right now is that at the bifurcation, that if you see the disease which we had when we filled by the collateral, see this here, that at the level of bifurcation, there is also significant disease.
Right.
So now it has to go down at that level. That it's get one more torque. What I'm going to do is just pull back a little more and then try to see if we can get into. We probably would not be able to go into the distal vessel because there is a very angulated. As long as we go to the horizontal vessel, that will be our goal. So just wait 1 second. Here. Okay. Go integrate right now. Good. No, 1 second. Don't give any more antigrade because there is a dampening now, significant dampening. Okay. Now go retrograde again.
You look to have created a subintimal channel right in the mid portion there.
Yeah.
Okay, come out.
Just 1 second.
Let's go with the.
Okay. Little dive with the side. Retrograde.
This one. Yeah.
No. Now it gets very complicated here. Complicated in the sense that multiple channels have been created right from the beginning. And how do you do it? Whether you leave this wire little bit and then go with the side by side, or how you do it. Now let me see. This looks a little better. Little die.
Yeah,
Yeah.
I think you're in the lumen now.
Yeah. Good.
Take a scene.
Yeah, not yet. I know, but just that now looks like that so far we have gone to central lumen. Same, the
No, take
little
a
drill.
picture
Yeah, no,
before you
1
do that.
second. Yeah, but tough because I am having a tough time to advancing the wire. That tells you that you may not be in the true lumen. Okay, give the side injection now.
There it looks a little more promising. Very hard to know.
Very hard to know.
No, it's on that section. Deep breath.
Yeah, you will die.
Bad.
Okay.
Let me take it out and let's see if we can get through this wire.
Yeah. Now with the same as we mentioned in our total occlusion strategy in February case, that once you fail once, rather than causing an extensive dissection, putting multiple stents, it's a reasonable, let it heal, bring back after 2 to 3 months, and then you'll have a better chance of succeeding.
Well,
so that
often you may even be surprised it may heal very nicely.
very nicely, and then require just a little bit of work distally. So that we are trying to see here if we can go with the, now tell us what your strategy is.
No,
what
I
you
want
to
to
do?
try with the confianza once.
More stiffer wire, and if we can get to the main lumen, fine. Otherwise, goal should be that we just go to the
Left
main
main.
circumflex left main and put a stent, but a stent has to be before this origin of the OM. Ready?
I do believe that's where the money is, because part of this is still you have an excellent result in the right. There are decent collaterals which hopefully will.
Ready?
Get us a LIMA guide.
So, I mean, once you have subintimal,
Sidles.
are you concerned putting in a confianza after that?
Well, I think as long as you just have a very, not pushing it, slowly rotating and drill.
Anu, quick question for you. What is the anticoagulant used here?
We have Angiomax. Initial was 270 ACT. Then we gave a half bolus. It's about 310 now ACT.
Okay.
Yeah. We actually very clear in terms of using Angiomax in these tough situations. We need that new.
The question always comes when you're doing a CTO, if you have a little wire perf, vessel perf, is Angiomax right?
Well, most people will argue that Angiomax
Yeah.
is perfectly safe there with its very short half-life.
Yes. And we actually, to support that, we have the CCI paper in February, and there was a rebuttal. Actually, I had the 2 letters to the editor, and we answered that question that yes, we didn't intend to, but once we used and we found it, that it became very user-friendly and there was no untoward outcome. Then in total occlusions, we routinely started using bivalvular compared to what used to be the practice not to use it. So that basically, I would say that this indication of the Angiomax for total in total occlusion came by default. Default in the sense that the cases did very well even after a wire perforation, and we are just talking about usually in the CTO you will get only wire perforation, and that those patients did extremely well compared to when used to be on heparin. and of course most of the time you end up in reversing heparin and still this happened. Complications in about 50% of the time either require pericardiocentesis or patient had bad outcome in hospital. So that we completely switch to it, and of course we are very careful that once you have the wire perforation, what we do is we stop the angiomax for about 20 minutes and if necessary do a balloon dilatation, close the port, and usually it suffice basically heals the wire perforation, then you go ahead and continue your work.
Well, but nothing compares more with incredible results. 5,900 PCI, nobody goes to surgery. That's a much more powerful statement than any editorial or rebuttal. This is just impressive data. Anu, what is your strategy here?
No, I think we have pulled back everything to have a different entry all the way.
My unpleasant task is to tell you we have 14 minutes to go.
Oh. Okay.
All right.
Give us a few minutes, things not looking good.
Which should not come in the way. I think this case has been very instructional. I do not think you should change your strategy just because we may be out of time. There have been various maneuvers which I think have offered a lot of practical benefit, I think, to viewers, as is also indicated by the caliber of the questions I'm getting. Samin, using more Procedural?
We actually now, we used to be in single digits. Now I would say in our lab about 20% of cases, but we are trying to learn because it still has issue with the bleeding. Many of these cases, despite using a 5 milligram maintenance dose, and with everyone, even with the multiple stents, giving only 81 milligram of aspirin, therefore use is increasing. I would say that I predicted 2 years ago that will be almost 50%, but there were a lot of issues in terms of insurances. The cost-wise has really decreased the overall use of so far, has been restrained us, but the more and more availability, cost is becoming a less of factor, so that it's more being used more. Now, should it become a routine? I think we are just about there now, that we'll have a clear-cut protocol that almost 40-50% of suitable patients should use the Procedural, yes. But I think it's just a very potent drug. We had to be anywhere there is a question that patient may have bleeding, it's not a drug to use. Even if it's the ideal, we think that's the case, because in the real life, you really have an issue. And the bleeding, as you know, the major bleeding occurred after 30 days. There's the maintenance phase, which is the more important in this part with a drug compared to even doing it for the short term. Now you want to take a picture?
That looks more promising there. It's the wire has
we'll
not
see,
tracked
but
yeah. Hard to, not sure.
No, there's no branch. Okay, so I think this is, for sake of time, the very simple, that what we should do now is that take care of the circumflex before the bifurcation.
You are in the lumen?
Huh? Then you want to pull back and try to go to the lower one.
No, that we should not. That's what killed us earlier. Let's just do the upper one and be happy.
Okay, good. Take it out. Good. Take the wire out then. Good. We'll see. Take the wire out.
What wire you have?
A Grand Slam. Okay, now let's see if we can get into the main lumen. We'll see now. We have which balloon we have now?
You've given up the habit of injecting through that to see where you are?
Yeah, that very rare. I'm not big fan of it, because we have seen some cases of spiral dissection through it.
Absolutely.
Because now if you see that if it goes, that you are going to see it very clearly.
Absolutely. Well, also with the contralateral injection, I think. Samin, use of abscessimag, more or less?
Yeah, this actually, you know what? I can tell you the more and more which goes with the updated guidelines, that they put both the small molecules and abscessimab in the same category of 2A and 2B, that optional, and there probably a less difference. I was a firm believer in high and complex cases that use of abscessimab, but few cases of thrombocytopenia requiring hospital admission for 5-7 days, that has really deterred that in about 30% of cases in our lab, 100% are done by using the Angiomax bivalvutin, and about 30% of cases will get 2B3A bolus. Now, of the 2B3A bolus, it's now almost 80%. Particularly with the large thrombus burden, will use epsiximab, but otherwise 80% of them will get 2 boluses of integralin. And of course, as you know, this is a very cost-effective strategy. The 2 bolus of integralin cost about 150, 160, and that is all we do in our cath lab, 2 boluses, and if we need to use epsiximab, we use 1 bolus. Therefore, epsiximab use has significantly decreased now.
Should I take a picture?
Yeah. So now, as you can see, Anu has done kind of Fogarty, and if we are going a native antegrade injection now, and we should be able to see that where the vessel is. Does not look good.
That does not look good at all.
Yeah. Okay. Now what we should do is that take care of the proximal, and then of course we'll take care of the distal segment later on.
Leave the wire there. Huh?
You want to leave this wire there?
Yeah.
Okay, good. So take this wire.
Okay, go up.
Okay, go up.
What stent?
Yeah.
23?
Yeah.
3 or 3?
3 or 23. 6, 8, 10, 12. We may need a 2.5 20 NC Voyager. Right now. No, but wire has to go to the main wire.
Why? It will stay there as long as you stop before the bifurcation.
Okay,
No?
take it off. Good. Now, this will be a very tricky that we need to stop it before the bifurcation. So now we can see, you know what we can do, a little modification. That if I know that the time issue and we were not able to into the main lumen, that this will be a very good case that for our June symposium, what is this now? 2.2, yeah, we need to open this lesion, angulated lesion, which have been there for a while with a 2.5 20 NC Voyager. So they had to, because then only your stent will be able to make that angulated turn, and initial expansion on, of course, will require post dilatation. So what we will do in this particular case, that clearly that we will not have a chance for the rotational atherectomy. It's of the LIMA distal LAD, that we will make it on June 17th, which is the Thursday for our live symposium, and that at that time we'll try both. Open this, give it a second try, second try for this total occlusion of the OM, and do the LAD rotational atherectomy via LIMA.
Anu, what do you predict will the OM look like in 2 months?
It will be a nice healed vessel. We'll be able to cross it with either Fielder, Whisper, and just balloon and stent it.
Or you may not even need to do anything.
No, I think you will.
No, we will.
That you, because reason, you know, I'll tell you why in this particular case. Because there was the second lesion after the total occlusion.
Right.
Because otherwise I would have agreed with, because we have seen some cases. Because I can tell you the classical case was, we have 4 years ago in our June symposium, Dr. Suzuki did the right coronary artery and could not open it. Dissected, did IVAS, everything, nothing. So 3 months later, 2 months later, we brought the patient back. It was unsuccessful on June 13th at the part of symposium. At 3 months later, that RCA completely healed. There was just a focal lesion in the distal RCA which required 1 single stent. But it was unsuccessful on day 0. But at follow-up, we didn't have to do anything, just put 1 stent.
I moderated that case and remember it well.
Yeah.
And you don't forget easily working with Dr. Suzuki.
I think we had to go to the main vessel, the wire.
Why?
Yeah. Yes. Because now question is,
You can place it right there.
okay.
The stent. Is the stent or no?
Yeah,
No, take it out. Don't break.
Yeah.
You don't want the wire in the main.
That's what we are
debating. Now. Right.
Yeah.
I'm telling him it's okay, leave it there, just place the stent before the bifurcation and come out.
Right.
Yeah, that actually very good also, because that will keep the lumen.
Well,
because we need the circlumen.
And only question is in that unfortunate situation of having a distal dissection, then you would.
No, but what we'll do is, we can, if necessary, we can go through the stent struts into the, because we saw the proximal. You know what, actually, you know what, it may not be bad in this particular case, that you do a stent, secure your OM, and then go through the stent struts and open the distal circumflex. Or
we don't need to.
Yeah.
You can place it just before the distal circ and OM.
Okay. Now this is the 3O.
3O23.
23 Zions. The proximal part of the left main may require a different one, but we'll see. Okay, want to take a picture? Good.
Okay, I'm going to pull
Yeah,
back.
pull back a little bit. 1 second. Yeah.
Why you bring it to this side a little bit? The same. Yeah.
So this is the Zion stent
Yeah.
and your workhorse.
That's it.
Now-
pull back a little more.
Tell me a little bit more about it. There is no balloon overhang beyond those the markers.
No, there is still actually the balloon is there, but the stent is at the marker. There is the new Zions, which is the the Zions prime has a very little overhang, but this is still the Zions, and we were part of the split prime trial, and you need to have guide a little bit so you see. Yeah, now that this but stent is exactly at your marker. Is this good?
Go up.
Good. Yeah. And but there is a balloon overhang, and that's where it's a compliant balloon, and this is where the issue comes that in the
now what I'm doing is pulling the guide out as they inflate.
the 10 atmosphere. Yeah.
Also, a decision point of view, I don't have any White House administrative
3.5.
presidential order telling me that we have to immediately knock off at 10 o'clock. How do you want to do? You want to go a few minutes beyond, or we are just otherwise 3 minutes from 10 o'clock?
Yeah. So we will see. I mean, I think we definitely want to open this the part
left-
of the
left
circumflex, the left main, and if we require a few extra minutes to go over, clearly we will not be able to do now our LED, but I can assure our viewers, good, it is there.
What was the size of the Zion stent there?
3O23.
And clearly that
You want to do
proximal,
post?
yeah, proximal. We have to dilate with a 3.5 20 MC Voyager
For the left main rail.
for the left main.
Right.
Cut it or no?
Have you had cases, I mean, where you would high pressure inflate only a part of the
Yeah.
longer stent?
Many of them, and actually particularly with the Zions, knowing that it's the same stent, that not worry about the various cell size, so that it's completely fine. It's the balloon which determine where it's the same stent, whether it's a 2.5, it's a
And you've had a chance to look at it with the IVUS to see that
that proximal half, even with the stent boost. Actually, I could have shown you stent boost today, but with little glitch here, it's not working. But you can see the stent proximally as a funnel, opening proximally, and then it's the stent tapering stent. You can call it a tapering stent. Yes, we can do, and it's a very simple, particularly with the Zions, knowing that we are deploying the stent at a low pressure, 10 to 12 atmosphere.
Is this a new balloon you have
Yeah.
or a used one?
Yeah, this is the new balloon.
Okay, there it goes. The left main and the proximal circ looks very good, even
Yes.
there with just 3.0. So this is a 3.5 now.
This is 3.5,
Okay.
16 atmosphere negative, and then we are going to bring it to the ostium, knowing that the ostial will be the important part when patient comes back for part 2. And as I mentioned, that clearly that second attempt in the total occlusion, rather than dissecting, and so like in this particular case, we did not dilate. Once you are dilated, it's a little issue, but you know there is a pioneer catheter which it's on this concept of your outback technique of the periphery, that you go through the subintimal space and then distally you confirm it and make a puncture into the distal vessel.
So no problem from insurance point of view bringing such patients back. I know in various parts of the countries where HMOs rule our life, some of these can become very tricky issues.
Well, that I think will be true for everyone, and will be true here. But at least even in the new Obamacare budget, the stage intervention is allowed, because every studies have shown that there are some group of patients where stage intervention is preferred rather than doing a multi-vessel intervention at the same time,
Well,
because those are the cases will get into more trouble.
Particularly in cases like this where all options have been exhausted. The patient who's had his CABG.
All right, I think we are in about time, and if it looks okay, we are going to, we know that there may be a slight distal pinch of the distal circumflex, but that I am not concerned about. Our goal is that the distal circ is fine, good flow, and there is still that lip of that OM1 is still remain patent at end of the procedure. That means, and you can see here, yes. Now we can do another view, take this one out, and look at very classical side branch, camera down a little bit, that side branch from point of view, there is no dampening, very nice ostium, LED is good, no issue from the LED point of view. Yes, disappointing from the OM point of view, but somehow this, we say that yes, we do the best thing, and sometimes that's best is not enough at one point, but the second time should do very well. Go, very good. So you don't need to do anything to the OM. To the OM as well as the distal circumflex, which gives the posterolateral branches, always was the mild diffuse disease. Left main is perfect, your LED is perfect. So I think if for all practical purposes, we are okay for today's work. We needed to have been a little better, but in this particular case is fine, and you will see this patient back on June 17th or 18th, preferably 17th. We will bring it on Thursday, and that time we'll go through the same issues, but probably what I'll do next time is we'll do a rotational atherectomy of the LED first, because that LED, as one of the viewer asked that question about the LED, we'll take care of the LED and then go after that OM, because we know that OM gets collateral from the right coronary artery, that even if it is just collateralized and remain less antegrade flow, it's still not end of the world, but basically that it's opening the LED, opening the circumflex, right coronary is open, in my opinion, should do good for this patient on a long run.
Anu, final comments from you. I do think that despite not being able to achieve everything we had in mind, which itself is a lesson to me, I think the beauty of all this is knowing when to stop. But any final words from you? I thought that was an excellent demonstration of the venture capital.
The only, I think just like you mentioned, every interventionalist, as we are trying to go to next level, higher level, and trying to do tougher cases, we got to know our limitation, and that's what we did in this CTO. Once we knew we were subintimal and we're not reaching the distal vessel, don't dissect and make the vessel worse and make it worse. As you see that, we stopped there, and nothing wrong in bringing this patient next time, and it will be, for the viewers, you can see it when he comes back during June. We may in fact see a nice antegrade flow, and all we will have to do is go through that. You already see a nice channel there. We'll be able to just put a stent, and the distal vessel, everything looks good. And the most important, I think, teaching point of this is to know when to stop.
And if we can put our the take home message, the last slide of the presentation, just to sum it up, that clearly that in these patients, that optimal technique and strategies are crucial to avoid any potential complication, and key is that outline your clear-cut interventional plan before proceeding in these complex cases. And of course individual devices, that your plan was clear-cut, but of course the plan may not work all the time, but you knew exactly what to do. Discuss these complex cases with the colleague, with your fellow, with your associate. Many places the cardiovascular specialist or nurses which are working in the room, so that you have the strategy, the devices ready, and change the strategy. Like in this particular case, we a little detour, but first, life is about the choices. This guy will have a second choice, a second chance, and we'll see him in next 2 months later.
So, final thoughts I have is exactly going on the question which was posed by one of the viewers, that how do you do 6,000 cases with no complications? This is exactly the illustration. Know the options, know when to stop, do no harm. I think this was an outstanding case from many point of views. I also thought your didactic on the practical aspects of syntax was most outstanding. We conclude today's session. We'll be back next time, May 18th. We'll see you then. Sameen, congratulations again to you and your team for an outstanding case.
Okay, thank you.